ये वाला है ना।
चलो तो वहां से हट गए।
ये मेरे ये वाला नेक्स्ट टॉपिक मोर्टेलिटी एंड मॉर्बिडिटी एप्रल एडिटेड के नाम से इसको। बिल्कुल।
डेट्स कितने हैं तुम लोग?
कितना मतलब।
हो गया
मार्च में
ये
देख पाओगे ना?
हाँ।
हम अपना और इनका सिर्फ पीपीटी खोलते हैं। आपका कौन है? ये तो इनका है।
एक महीने मेरा है।
हाँ और ये
मार्च में। और हमारे यहाँ इसे
एक नंबर पे
है रजिस्टर।
तो बाकी कहाँ गई?
वही तो
वो कहाँ गई?
हो गया।
तो चार्जिंग है ना, चार्जिंग तो खूब
तीन तुम्हारे गए।
ये तो
कौन सा
इनका
डिपार्टमेंट?
सबका
देखो इतनी मोर्टेलिटी तो नहीं। क्वेश्चन तो उठ जाएगा वहां पे। 7 डेट्स है, कितनी हमारे यहाँ रजिस्टर में? 1 मंथ मार्च।
आप कितने मानोगे?
तीन है।
पहले कुछ ना बताओ।
वो चलते रहते थे ना, तो 30-40 होते थे। 50 हो रहा है ये। बट ये 87 का क्या रहता है? 33 डेज, 34 डेज का हुए, 15 इनके हुए, 31 डेज, 31 डेज का हुए। बीच में कहीं रास्ते में।
इस बार तो नहीं, हमारे तो लंबा भी नहीं गया पढ़ने में।
तो 3 ही डेज से टोटल पक्का मार्च मंथ।
हाँ भाई।
यार अटेंडेंस डाल दो।
अपनी मर्जी से बच जाएगा। चिकन टिक्की वैसे। हाँ गौरव।
मैंने रोलेक्स और सीपीओ नहीं डाला।
अरे यार बहुत जरूरी है।
आनंद से बैठ के करा था मैंने, मतलब करा था। ओएनएस भी डाला। अमोनिया ओएनएस भी डाला है, सीपीओ नहीं डाला।
नीचे से।
करो भाई। खबर में बस छोड़ दो।
नाम हाइड कर। Good morning, everyone. So today's mortality and morbidity meet from Department of Hepatology. I am Dr. Shreya Singh. So the monthly statistical report. In hepatology, there were 927 admissions in the month of March 2026. And discharges were 911 with a median length of, with a length of stay being 5,707 with an average length of stay being 6. Total deaths in the month of March were 87. Deaths in hepatology were 53. Specialty wise, detail of outpatient total patient number. So in hepatology, there were 7185 in March 26. List of procedures from hepatology: upper GI endoscopy 958, APCs 24 were performed, colonoscopy 42, sigmoidoscopy 24. Total 251 EST EVL were performed, EUS 46 were performed, and TJLB 41, HVPG of 57. And ERCPs were 102. And these were minor procedures. Coming to today's morbidity first, the list of iatrogenic related morbidity in patients. So first patient is Mrs. Chena C.S. Devi, 58-year-old female. She has comorbidities in the form of hypertension and atrial septal defect. She presented to us with choledocholitis. Her ERCP stenting was done on 30th of March 26. Post ERCP, she developed post ERCP pancreatitis. Her amylase lipase were high, following which TPN was initiated. She went into refeeding syndrome post that and developed dysalkalitemia. She had hypophosphatemia, hypomagnesemia, and hypokalemia, which precipitated atrial fibrillation with fast ventricular rate in a background of congenital heart disease, AST with severe PAH. Her stay in ICU, she was then shifted to ICU in view of atrial fibrillation with fast ventricular rate and hypotension. She had a brief stay of less than 20 hours in ICU. Her electrolytes were corrected. Atrial fibrillation reverted back with beta blockers and electrolyte correction, and she was initiated on anticoagulants and shifted to ward. Next patient, RNS, 70-year-old male, case of multifocal non-cirrhotic HCC, segment 6-7, newly diagnosed hepatitis B positive with a DNA load of 85 copies per microliter. With BCLC-B status and AFP of 133 and PIFCA of 43109, with comorbidities of COPD and hypertension. He was admitted in the ward from OPD for further management plan, but had iron deficiency anemia, for which he had received ferric carboxymaltose injection in the ward, following which he developed anaphylactic reaction and went into cardiorespiratory arrest. He was intubated in the ward and shifted to ICU. He had cardiogenic and anaphylactic shock, was started on NORAD at 1 mics per kg per minute and also ADR 0.2 mics per kg per minute. Over the next 2 days, his vasopressor supports were tapered and his PF ratios improved to 250 at an FiO2 of 40%. His weaning trial was initiated, following which he had type 2 respiratory failure, respiratory acidosis with hypoxemia. FiO2 increased rapidly to 85%, and despite all efforts, FiO2 remained high over a span of next 3 to 4 days. Subsequently, then, there was a gradual improvement with decreasing FiO2 requirement, and the patient was successfully extubated over the next 3 days and discharged. The third morbidity was a 62-year-old female, case of diabetic hypertension and CAD post PTCA, case of cirrhosis NASH, decompensation in form of ascites and acute variceal bleed, had refractory ascites for which she was on paracentesis sessions. She had post-ascitic TAP hemoperitoneum, following which CT angiography was done, which revealed no contrast extravasation. Vitals were monitored closely. PCD was then inserted and low volume paracentesis was done daily, following which ecosprin was also reinitiated and patient was discharged. Now, a mortality, a post-contrast intubation followed by mortality for patients. So 60-year-old male, case of acute on chronic liver failure, acute being DILI-related, history of Giloy use, and chronic being NASH-related. He had uncontrolled diabetes for past 20 years and microvascular complications in the form of proliferative diabetic retinopathy with maculopathy and also diabetic nephropathy. He also had macrovascular complications in the form of CAD, for which he was never treated and was undiagnosed even at presentation in the hospital. He had ischemic heart failure with reduced ejection fraction. His endoscopy, which was done prior, had grade 2 varices with RCS, for which primary EVL was done outside. He was a non-bleeder in the past, but later in the hospital stay, he had a bleed episode. So his current issue, when he presented to us, he basically presented with these with the ACLF presentation, worsening jaundice, and for further workup in ward, for which he was shifted for a CT, and a post-contrast in the CT scan, he developed shortness of breath, tachypnea, and he was shifted to ICU. He was intubated and likely it was anaphylactic shock, following which fluid bolus was given, and contrast-induced volume expansion can also be one reason that caused volume overload. That resulted in acute pulmonary edema, and he had bilateral pulmonary infiltrates. He had poor PF ratios, type 1 respiratory failure. He also had acute on CKD with a KDIGO2 creat of 2.1 and progressive jaundice with bilirubin of 22. On the day of intubation, this was his chest X-ray. In a span of about 2 days, he was extubated. All his miniball cultures were sterile. So this was the pre-extubation X-ray, and this was the post-extubation X-ray. Even post-extubation, there was worsening pulmonary infiltrates. And his echo showed a dilated heart with an ejection fraction of 45%. And he had RV was dilated, and IVC was 24 to 20 mm with an estimated RA pressure of 15 mm. He was initiated on Lasix bolus dose, followed by initiation of Lasix infusion, to which he responded well. His urine output also improved and tachypnea also improved. His oxygen requirement started tapering, following which he developed a nosocomial pneumonia. Sputum culture came out to be positive for Klebsiella pneumoniae, log 5 colony count, for which sensitive antibiotics were given. In a span of 9 days post-extubation, he was shifted to HDU at 2 liters of oxygen with a creatinine of 1.08. But despite that, next day he had an episode of hematemesis with melena, for which upper GI endoscopy was done that revealed a post-tibial ulcer bleed, for which Tenicella stent was placed. However, he had shock with worsening AKI, for which he was shifted back to ICU in 3 days. His shock improved in the ICU and HB stayed stable, but had worsening AKI with metabolic acidosis, for which CRRT was initiated. In the next 2 days, his sensorium worsened further with type 1 respiratory failure and was re-intubated. Tenicella stent was also removed on day 7, following which in a span of 2 days post-intubation, his PF ratios improved and he was extubated again. But post-extubation, he had new onset septic and cardiogenic shock. His repeat focus revealed an ejection fraction of 25%, following which he had cardiac arrest and despite all resuscitative efforts could not be revived. So what are the contrast effects in cirrhosis? So coming to the renal effects first, so there has been made various studies in cirrhotic patients wherein they have shown that there is no significant deterioration in renal function post-contrast. CIN incidence in this study in 2009, 216 patients, cirrhotics. Citis was a major risk and there was 11% persistent renal dysfunction seen. Cirrhosis, when they had compared CT versus MRI, so the risk of contrast-induced AKI was higher in CT, 17.9% versus 5.9% in MRI-induced, gadolinium-induced AKI. Philomia et al. In 2016, 173 patients who with cirrhosis undergoing CT, they also showed that risk of AKI was high with the patients having ascites and female sex, and also infections increased the risk. Then these were other studies which showed in 122 cirrhotic patients with to look at AKI post-contrast, since CIN was seen in 5.1% patients and it was linked to higher MELD scores and hyponatremia. Then in 88 end-stage liver disease patients in whom angiography was done, again 23% incidence was seen. So, there was a study in the Journal of Hepatology 2023, which showed they had taken 2 groups of patients with cirrhosis 148 and with cirrhosis 133 and without cirrhosis 163. One group was given was exposed to CECT and the other group was not exposed. The incidence of AKI was 4.8% in the one exposed, and the one without contrast exposure was 1.5%. And in the normal population also it was 2.5%. So they had concluded that the AKI risk after CECT in cirrhosis is low and not significantly different from that of general population or of the cirrhotic population unexposed to the iodinated contrast media. It mostly consists of mild and rapidly resolving episodes of renal dysfunction, and it is not associated with tubular kidney injury. Patients with ongoing infections appear to be the only ones at higher risk of AKI. Then coming to contrast effects on heart. So it has been seen, although there has been no studies in cirrhotics per se, but it has been seen that use of contrast causes an increase, because hyperosmolar or isoosmolar contrast causes osmotic fluid shift into intravascular space. So that causes volume expansion and increase in preload that can precipitate cardiogenic pulmonary edema. Then periprocedural IV fluid administration also can lead to volume overload in patients who already have heart failure with reduced ejection fraction. Even depressed LV contractile reserve further augments because they are unable to take up stress. This acute hemodynamic stress further precipitates pulmonary edema in these patients. Then fourth mechanism is a contrast transiently increases the viscosity, which increases the SVR and decreases forward flow and increases LV pressure, which in turn can result in a failure. Contrast-induced vasodilation and neurohormonal activation. So this initial vasodilation also results in increased RAS and fluid retention and thereby can precipitate pulmonary edema. Also, non-cardiogenic mechanisms have been described in literature wherein endothelial injury or capillary leak can be seen post-contrast. Although it is rare, direct endothelial toxicity is the cause, but it is very rare. And heart failure patients have got, if they have got baseline endothelial dysfunction, then this can also be a add-on factor to the edema. Hypersensitivity reaction, so histamine release and vasodilation and capillary leak. So contrast triggers the immune reaction, and thereby it can cause non-cardiogenic and also mixed edema if there is presence of heart failure. So the stress won't be tolerated well, and it can precipitate pulmonary edema. Renal injury, so fluid retention and delayed. So because of the AKI, there is increased fluid retention and preload, which can in turn cause cardiogenic edema. Arrhythmias can also be precipitated by contrast, and also myocardial ischemia. And in cirrhotic specifically, latent cirrhotic cardiomyopathy on top of heart failure with reduced ejection fraction can in turn add to impaired stress contractility and diastolic dysfunction that can worsen the existing HFrEF. Diastolic dysfunction with high LV end diastolic pressure. Even small preload rise sharply increases LV filling pressure and thereby can precipitate pulmonary edema. There haven't been any studies in cirrhosis. Only these few studies I could find wherein 40 patients, cirrhosis patients were taken. Contrast use has not been seen, but definitely procedure and stress related blunting of systolic response to stress has been seen in this study. Then there's a review wherein they had mentioned about the cirrhotic cardiomyopathy and diastolic dysfunction and impaired contractility, and a cohort study wherein 60 patients were taken, and they were given procedures were done for them, and acute hemodynamic stress resulted in precipitation of heart failure, and fluid and contrast were one of the factors that precipitated heart failure. But there is no per se studies to look at contrast and heart failure and their outcomes. Coming to anaphylactic reactions to iodinated contrast, again, there are no studies in cirrhosis patients, but in general population, they have mentioned that there are mild reactions only, which are usually taken care of by conservative management. Only a few case reports of severe pulmonary edema requiring ICU care has been mentioned in the literature. So the take-home points would be in cirrhosis, contrast-related adverse outcomes are rarely due to direct toxicity. They result from a combination of hemodynamic stress, impaired cardiac reserve, and an iatrogenic fluid administration, leading to a cascade of complications, that particularly in patients with underlying cardiac dysfunction. Thus, before contrast administration to any patient, cardiac assessment should be done first, followed by sepsis screening to minimize contrast-associated negative outcomes. Thank you. The next mortality would be done by Dr. Vinay.
Very good, Shreya. This was quite educative. From this time, we're trying to present both morbidity and mortality, but very well done. A lot of education. I hope this didn't occur. Should not have occurred that a patient with contrast, has so much complications. Okay.
Good morning, everyone. My name is Dr. Vinay, and I'm presenting a mortality case from Department of Hepatology. So this is a case of 22-year-old female PK from Uttar Pradesh with no known comorbidities. She presented with initial prodrome of 2 days of fever, followed by jaundice, after which she had altered sensorium 3 days later. So clinical diagnosis at that time was hyperacute liver failure, probably viral, with a history of prodrome. She was initially admitted in SGPGA, and evaluation was done. Her INR in SGPGA was 7.6, and in evaluation all the viral markers were negative, and hepatitis A and hepatitis E was negative. Urine 24-hour copper was 384 microgram per 24 hours. So on arrival, she was conscious as rated, GCS of 14/15, heart rate of 114 and MAP of 83 without any support. She was requiring 2 liters O2, maintaining saturation of 98%. Her baseline lab parameters showed HB of 12 and total counts of 15.7. Her PT was 63.9 and INR was 5.79. Ammonia was 188.4. Bilirubin of 25.6, and AST ALT was 1,237 and ALT of 344. Her ALP bilirubin ratio was 6.9 and AST ALT ratio was 3.59. In view of high INR 7.6 outside, on admission itself, she was told for upfront transplant. So working diagnosis in day 1 of ICU, hyperacute liver failure, etiology under evaluation, jaundice to encephalopathy less than 7 days, KCS absolute criteria was 1:1. Her initial imaging as per the protocol showed no lesion, no edema in the CT brain. HRCT thorax showed no abnormality, no infiltrates or no effusion. NCCT abdomen showed liver of 12.5 centimeters, normal outline. Liver volumetry was 856. So, course during the ICU, patient was initially advised for transplant. They did not have any donor. As they did not have any LD option, first session of Plex was done on the day one. So, other investigation wise, etiological assessment was done. Her ceruloplasmin was 0.17, 24-hour urine copper was 382. All other atypical viruses and bacterial analysis was negative, and her urine routine was normal. So this was the course of laboratory analysis during the course of the hospital. Her vitals were relatively stable. Initially, EEG showed only mild slowing, but there was no evidence of encephalopathy. Her INR was 6.27 when she underwent first cycle of Plex, after which was corrected to 1.25. Plex, 4 cycles of normal volume Plex were done, which are marked here with the orange color arrow marks. And initially she had good response to Plex, following which she has reduced response. On day 3 of the course in the ICU, she had a drop in sensorium. And ammonia was also slightly increasing. She was initiated on CRRT. Patient was intubated on day 5 when she developed encephalopathy grade 3. Patient had rebound ammonia of 416 during that day. In day 5 of ICU, her vitals were relatively okay. The reason for intubation was the drop in sensorium. This was her ABG during that post intubation. On FiO to 45%, she was maintaining 268, and her pH and lactates were relatively okay. So this is the same chart which I have shown. And next, this is the course of the LFTs during her hospital stay. So initially the bilirubin was 25. Then after first cycle of Plex session, it was 13, relatively stable after that. She had poor response to Plex after that. She was repeatedly counseled for transplant, but they were not willing even for DDLT listing. And one more important point to highlight, her AST and ALT had stark decline on day 2, which will indicate a poorer prognosis. These are the graphs showing the trend of ammonia and INR. So there is a rapid rise of ammonia on the day 5, on the day of intubation, where it was 419. And INR was initially responding to Plex, but later on it was gradually increasing, reaching a peak IN of 9.68. So this is the AST-ALT trend. So there was a rapid decline on day 2. So course, she was continued on CRRT and Plex session. Patient had progressive worsening INR. On 25th, she went LAMA and succumbed 1 day later at the local hospital. So points to discuss: Wilson presenting of ALF. How common is it? Reliability of Wilson parameters and diagnosing of Wilson's disease in ALF. What are the treatment options? So the prevalence of ALF, Wilson accounts for 5% of all ALF cases worldwide. Wilson's disease ALF is associated with almost 100% mortality unless diagnosed early and treated. So few clinical features which are more specific to Wilson's in ALF: severe Coombs negative hemolytic anemia, coagulopathy, and response to vitamin K. They have only modest increase of AST, which is less than 2000, normal to subnormal ALP less than 40, rapid progression to renal failure, and female to male ratio is 2:1 to 4:1. So investigations in ALF for a diagnosis of Wilson, the sensitivity and specificity was mentioned by Coleman et al. In 2008. So the ceruloplasmin is a negative acute phase reactant, so it has less sensitivity, and the specificity is 84%. Other than that, they have used ratios for diagnosis of Wilson's disease in ALF. ALP is to bilirubin ratio less than 4 has 94% sensitivity and specificity of 96%. AST is to ALT ratio is greater than 2.2, the sensitivity of 94% and 86%. By combining both these markers, they have almost 100% of sensitivity and specificity, is what it's mentioned. And serum copper almost always exceeds 2000 milligram per deciliter in all ALF patients with Wilson disease. So I couldn't find much of Plex data in Wilson's. So this is including all the ALF. This is a study done in 2022 by Maiwal et al. So it is an RCT compared standard medical treatment with plasma exchange, which showed higher transplant-free survival rate in 21 days. 75% was 45%. Stahl et al. Is a retrospective study of 40 people, which is a toxin related ALF. They did daily low volume plasma exchange. The 30-day survival actually did not show much of significance, but the vasopressor support decreased. Larson FS et al. Done in 2016. It is the largest study which is done on paracetamol related ALF, which showed overall survival of 58% versus 47.8% when compared to standard volume, standard medical therapy, which is high volume. And Veserma et al. It is a retrospective study done in paracetamol poisoning. 6 patients survived without LT. So one study which I could find regarding high volume plex in Wilson's disease, which is done in ILBS by RPP and SEMA et al. Here, high volume plasma exchange plus standard medical therapy was compared to standard medical therapy alone. The total number of patients which were collected was 43. These were in pediatric population. 37 patients were 7 patients were excluded and 37 patients were included. This measured the 90-day transplant-free survival. So the result was 47.3% of patients in high volume plasma exchange group had survival versus 16.6% in standard medical therapy group.
To
So-
summarize, Vinay, we are running out of time. Summarize what is the issue in this case. Just
how to
come
treat ALF Wilson's disease
Yeah,
when you
so
don't have a
quickly.
transplant option?
quickly. Yeah.
Actually, Plex is Wilson has almost 100% mortality without a transplant. So Plex is usually a bridge for a transplant, and there are not much of studies where Plex alone has been tried. There are a few case reports which was mentioned in this case report. According to literature review, Plex, which is used as a therapeutic rescue therapy, 40% have survived without transplant. That's
Any comments? This patient went Lama, am I right? If I remembering,
yes, sir.
and we consider that we might have lost, and we tried very hard for Shastri. Any comments? Shastri there?
Yes, they were not even willing for DDLT testing. So, and the next day after they took, she expired at hometown hospital.
Liver biopsy would have been very useful, but you can't do in that. And also that her urinary copper was high, so she was treated like ALF, but could not be saved despite Plex. Okay,
Thank you, sir.
all right.
Good morning, everyone. Today I'm presenting mortality and morbidity on Department of HPV and liver transplant. In this month, we have performed 13 adult liver transplants, 2 pediatric liver transplants, and 2 DDLTs. In January, we performed 13 liver transplant with 2 mortalities. In Feb, we performed 14 without any mortality. In March, we performed 15 with 1 mortality. And in April, we performed 15 with 3 mortalities. Regarding elective surgeries, this month we performed 4 major hepatectomies, 4 hepaticojejunostomies, 3 Whipple's pancreaticoduodenectomies, 1 PSRS, 3 extended colis, 1 Kasai procedure. And regarding emergency surgeries, we have performed 3 exploratory laparotomies and 3 tracheostomies. Now coming to morbidities. Mr. SC, 61-year-old male, CLD NASH with MELD3 of 18. He underwent live donor liver transplantation on 12th March. But the patient this month developed multifocal intracranial bleed superimposed with fungal and bacterial pneumonia. As a result, he was intubated on day 30 of liver transplantation and then tracheostomized. Currently, patient is on POD 59 on hydrotrack resolving bleed and transplant HDU with normal Doppler and LFTs. Mr. M.A., 53-year-old male, CLD NASH patient with MELD3 of 15. He underwent ABO incompatible right donor liver transplant on 24th March. And in view of patient was intubated in view of respiratory distress and was found to have mucor. But there was inability to wean off from the ventilator, so he was tracheostomized on POD 21. Currently, patient is in transplant ICU, conscious oriented on hydrotrack with normal Doppler and isolated hyperbilirubinemia. Mr. T.S., 4-month male, CLD biliary atresia. He underwent live donor liver transplantation, left lateral lobe with left renal vein ligation and portal vein patch venoplasty on 24th of this month. In view of reduced portal flow and hemorrhagic drain output, he was re-explored very next day. Currently, patient is in transplant ICU on ventilatory support, POD6, with normal Doppler and improving LFTs. Now coming to mortalities. Mrs. SK, 51-year-old female, CLD HCV with decompensation of ascites, AVB, jaundice, AKI, and MELD3 of 17. She underwent live donor liver transplantation left lobe on 27th Feb and was re-explored with hematoma evacuation on 18th March. Her immediate cause of death was bilateral bacterial and fungal pneumonia with septic shock, and antecedental causes were multi-organ dysfunction syndrome, sepsis-induced graft dysfunction, bilateral pleural effusion, coagulopathy with GI bleed, and acute kidney injury. Mr. GS, 34-year-old male, ALF HBV with high viral load. He underwent live living donor transplantation on 10th of the April, re-exploration on 11th April, and tracheostomy on 15th April. His immediate cause of death was intracranial hypertension leading to brainstem herniation and refractory septic shock with coagulopathy. Antecedental causes were bacterial pneumonia and sepsis-induced graft dysfunction. Mrs. BD.
This patient, the ALF guy, why did he get post-transplant? Was it because of ventilatory problems? Or so?
Sir,
Why did he get herniation?
I'll present this mortality in detail.
You will present?
Yes.
Okay.
Mrs. BD, 50-year-old female, CLD ethanol with MELD3 of 18. She underwent left living donor liver transplantation on 16th April. Her immediate cause of death was severe septic shock. Her POD2 and POD6 blood drain and ET cultures were suggestive of Acinetobacter baumannii. And antecedental causes were multi-organ dysfunction syndrome secondary to bacterial sepsis, sepsis-induced graft dysfunction, and early allograft dysfunction. Now coming to mortality. Mr. GS, 34-year-old male with body weight of 80 kg. Date of admission was 7th April. Date of surgery was 9th April. And date of death was 21st April without any comorbidities and no previous surgeries. Now coming to history of the patient. On 2nd April, patient started experiencing fever and vomiting, for which he consulted to Locker Hospital. On 6th April, in view of worsening of symptoms, he get admitted in private hospital outside, and where he was evaluated and found to have deranged LFTs, and HbS-Ag was found to be positive. Very next day, patient developed altered sensorium. Patient was intubated there only and then referred to ILBS hospital. Patient was received in emergency with pupil bilateral 6 mm and ONSD of 0.6 and 0.5. Patient was admitted under hepatology department with INR of more than 4.1 and ammonia of 560. CRRT was started. First cycle of Plex was given. Next day morning, donor evaluation was also started. Post-Plex INR was 1.4, ammonia was 300, but there was rebound increase in INR to 3.3, ammonia to 513. Second cycle of Plex was also performed. At that time, pupil were bilateral 4 mm reactive with ONSD of 0.5 and 0.5. And then next day morning, in view of worsening of INR and ammonia, patient was planned for liver transplant. Patient's pupil were dilated with anisocoria with sluggish reaction. CT brain was done, which was suggestive of cerebral edema with intact vascularity. Pre-op multiplex PCR was suggestive of Acinetobacter and Pseudomonas. On the same day, 9 p.m., patient was taken for live donor liver transplant after high-risk consent and neurology clearance post-CT angio. These are the preoperative investigations, and there was rebound increase in INR post-Plex also and ammonia increase also. Now preoperative workup. In preoperative workup, blood and urine culture were negative, but multiplex PCR was suggestive of Acinetobacter baumannii and Pseudomonas. HbS-Ag was positive with higher viral load of 5.8 log 7. And patient's imaging was done, in which CT brain was done, which was suggestive of diffuse cerebral and cerebellar edema with normal cerebral angiography. And this is the preoperative HRCT showing some ground glass opacities. And this is the pre-op NCCT of the patient, in which there was no evidence of ascites with mild hepatomegaly, no splenomegaly, without any ascites. This is the pre-op CT-NG of the brain. There was mild cerebral edema with intact vascularity. So patient was diagnosed with acute liver failure, HBV related with high viral load. His wife, Mrs. K, 32-year-old female, came out as prospective liver donor. She was evaluated. According to our protocol, CT was done, liver volumetry was adequate. Therefore, they were opted for liver transplant. And then the patient underwent living donor liver transplantation, right lobe graft on 9th April. Intraoperative findings were suggestive of minimal ascites, liver enlarged pale with regular margins, GB distended, arterial portal venous anatomy were normal, and hepatic venous anatomy was also normal. So standard outflow reconstruction was done with two inferior veins, standard portal vein, arterial anastomosis was done, and two duct, two anastomosis for biliary duct was performed. Cold ischemia time was 60 minutes, anhepatic phase 159 minutes, out of which portal cable shunt was 98 minutes. So intra-op Doppler was also normal. The biopsy report, it was suggestive of marked acinar disarray with extensive periacinar.
Go back to the gross. Many people have not seen the acute liver failure liver, so this is just for people to see. There is no nodularity, but there seems like there is chronic hepatitis in this. This is not pure ALF. Let's see what the biopsy says. Next.
So there was extensive pan-acinar and multi-acinar necrosis with parenchymal collapse involving 80 to 90% of the parenchyma with features consistent with acute liver failure. So now coming to post-operative course, on POD0, patient was shifted to transplant ICU on ventilatory support, sedated and paralyzed on inotropes of NORAD and VASO. Shifting lactate was 3.1, Doppler was normal, pupils bilateral dilated 6 mm, CRRT was restarted at 35 ml per kg per hour, ONSD was 0.63 and 0.6, mannitol was given TDS, drain output was mild hemorrhagic, coagulopathic correction was done. On POD1, patient had coagulopathy for which correction was given. Patient developed hypothermia, hemorrhagic drain output, borderline urine output, and in view of HB fall, patient was re-explored and hematoma evacuation and hemostasis was performed. Around 1 liter hematoma was found in lesser sac with altered pancreatic surface suggestive of hemorrhagic pancreatitis. ONSD was 0.66 and 0.69, pupil bilateral 5 mm and non-reactive. Cultures that were sent before LT showed positive throat culture. Graph Doppler was normal, and in view of positive throat culture, antibiotics were upgraded to Zevicefta, Metrotico, and colistin. Antifungal were also upgraded. This is the pre-op nasal swab suggestive of Acinetobacter baumannii, sensitive to Ilorus and colistin. Very next day, patient still had coagulopathy. Patient developed fever followed by septic shock, and his inotropes started rising. Patient had cerebral edema. Bilateral pupil were dilated 6 mm without any reactivity. BIS score was persistently 0. Patient had AKI. ONSD was 0.56 and 0.6. Lactates were decreasing, and patient was on mechanical ventilator with FiO2 of 45. Graph Doppler was normal. On POD3, septic shock worsens. There was persistent inotropic requirement. Coagulopathy, tech-based correction was given. Pupils were dilated. Anisocoria developed. Right-sided 7.4 mm and left-sided 6.3 mm non-reactive. Patient had rising lactates. ONSD was 0.62 and 0.64. TCD, no vessel was seen. CMV was non-detected. Blood and urine culture was non-detected. ET culture was sent again, which was again suggestive of Acinetobacter baumannii. Graph Doppler was within normal limit. On POD4, patient still had septic shock. ONSD right-sided 0.64, left-sided 0.67. Rising lactates. HBV DNA was repeated, which came out to be log 4. AKI, coagulopathy, sedation was stopped, but there was some spontaneous breath efforts were present. ONSD was still 0.62 and 0.64. Graph Doppler was within normal limit. This was the bilirubin trend. It started from 10, it dropped down to around 2.5, then it started rising again. And for AST-LT also, it started from 2000, came down to 150, and then started rising again. These are Doppler pictures which show normal vascularities. On POD5, atracurium was stopped. Some breathing efforts were still present. Hence, the decision was taken to perform the tracheostomy of the patient. Lactates were slowly rising. Patient was AKI on CRRT, ONSD right-sided 0.65 and left-sided 0.64. Graph Doppler was within normal limit. The gram staining of AT secretions were sent, which were suggestive of GNB with pus cells. On POD6, pupils are still dilated with anisocoria. Sepsis-induced graft dysfunction settles in. GI lavage showed altered blood. Tech-based correction was done. SDPC transfusion was done. ONSD right-sided 0.6, left-sided 0.6. EEG was performed, which was suggestive of low amplitude artifacts only. Neurological reference was done, and the CT angio was advised. Graph Doppler was still within normal limit. On POD6, culture again was suggestive of Acinetobacter baumannii. On POD8, pupils were dilated with anisocoria. Tech-based correction was done, and anuria developed. There was increased inotrope support. ONSD raised to right-sided 0.7, left-sided 0.68. FiO2 was 60% with slowly rising lactates and increasing inotropes. CT brain was done, which was suggestive of diffuse cerebral edema without any vascularity. CT abdomen suggestive of intact graft vascularity. This is the CT abdomen. Arterial phase, showing the arterial vascularity of the graft. This is the
This is not very, this is differentially perfused graft.
Yes, sir.
This is not very well vascularized. At least 40-50% of the liver shows hypodense. Maybe comments from a radiology, Deep or somebody, or Shalini. Any comments, Deep? Yeah. What do you feel, Shalini? Is it well perfused or?
Yeah. This is just the arterial phase. We need to see the later phase.
Show the venous phase if we have. Just for learning.
You have the third phase? Do you have the third phase?
No, ma'am.
Okay, so as far as the portal venous phase goes, yes, the liver definitely appears heterogeneous. And I do see that collection still there, right next to the cuttage, isn't it?
This is
There is
CT
a
angio
collection
brain.
right next to the cuttage still. I think you evacuated the hematoma, but there is a collection there, and the lesser sac also seems to be quite inflamed. Yeah, I need to see this. I haven't seen this case earlier. You need to stop there. So the liver is heterogeneous, right? It's not homogeneous. There's a lot of periportal edema. Can you stop right here? And that's the collection. That's the collection right next to the liver. And the whole lesser sac is also completely inflamed. So I'm not sure if the pancreatitis was resolved. So
Sure.
this is not,
Patient has a bit of pancreatitis component also.
no, yeah, it looks like quite moderate to
Yes.
severe pancreatitis. Let's go down. Is the pancreatic vasculature maintained?
No, ma'am. Pancreas is also heterogeneous in this one.
Yeah, it's totally gone. It's necrotic pancreatitis. It's severe necrotic pancreatitis. There's a lot of fluid as well.
CT angio
Just
brain.
for my learning, why did we make a portocable shunt? He's not a cirrhotic.
No, sir. In actually ALF, all the ALF, we do not manipulate liver as such because there is release of toxins. So first we make portocable shunt, we release out the liver, and then we mobilize the liver. Sir.
Okay.
This is the CT angio. of brain performed was suggestive of gross cerebral edema without any vascularity. On POD9, there was maximum inotropic support. Patient had anuria, pupil were dilated with anisocoria, sepsis-induced graft dysfunction.
Summarize what we could have done well, better.
So, patient then immediate cause of death was intracranial hypertension leading to brain herniation, refractory septic shock with coagulopathy. Antecedental causes were bacterial pneumonia and sepsis-induced graft dysfunction. Contributory causes were acute liver failure, for which live donor liver transplantation was performed. So in postmortem biopsy, it was suggestive of zone 3 coagulative and hemorrhagic necrosis, query, sepsis, and ischemic pathology. And postmortem lung biopsy was suggestive of focal acute lung injury with features of early diffuse alveolar damage. So challenges in our patient, and preoperatively, patient had positive throat culture, Acinetobacter baumannii, high viral load of HBV, cerebral edema with anisocoria, coagulopathy, and pre-op plex. And postoperatively, patient developed bacterial sepsis, coagulopathy, cerebral edema with anisocoria, AKI with metabolic acidosis.
Just to stop you here for a minute, in acute liver failure due to hepatitis B, you never see DNA. So the presence of DNA means it is acute on chronic. It is a flare of the hepatitis B. In ALF, Hep B, there is no DNA or no HbSAg generally visible.
Yes.
So clinically, he looked like the liver also looked ALF, but it is a flare of the chronic HBV.
Yes.
Go ahead.
So systemic manifestations of ALF, the most common, one of the most common causes of death are in post infections due to immunoparesis, neutrophilic dysfunction, and SIRS, and also hepatic edema, hepatic NCAF, brain edema, and intracranial hypertension. So in our department, we have performed up to a total of 140 liver transplants for ALF, out of which most common etiology was HAV, 33.8%, then HEV, HBV, and various other causes also. And almost 76% of the patients, they had grade 3, grade 4 HE. Pre-op LT-ICU stay was in 89.5% of the patients, and need for pre-op ventilation was 83.5% patients. So determinant of poor outcomes post-LT for ALF, there are various studies that were conducted. In Bernal et al., it was suggestive of age more than or equal to 45 years old, requirement of vasopressor requirement, and use of high-risk graft. In Germany et al., it was suggestive of recipient age more than 50 years, incompatible ABO matching, donor more than 60 years, or reduced graft size. Yuan et al., pre-transplant waiting time more than equal to 5 days. Hoer et al., lowest pH of recipient before LT less than 7.26 has worst outcome. Pamecha et al., post-operative worsening of cerebral edema, systemic inflammatory response syndrome, preoperative culture positivity, and longer duration of anhepatic phase. So predictors of post-LT sepsis, transplant-related factors. In this patient, we had indwelling catheters and deep lines, prolonged ICU stay, dialysis, prolonged ventilation, and repeat surgeries. And in recipient-related factors, we have prolonged hospital stay and catheter before orthotopic liver transplantation. Acute liver failure itself post-transplant has a poor prognosis. Presence of hepatitis B, C, or high viral load, and presence of previous infection, especially airway and urinary tract infections.
It's a tough case, a tough call. Any comments, Dr. Pamecha?
Yes, a very difficult case. Very difficult. So I think one of the element which was pancreatitis was there, because when we explored him on day 1, I think, because of bleed and drop in hemoglobin and hemodynamic instability as well. So this was all hemorrhagic. You typical see with pancreatitis, that type of fluid was there. It was all, there was no active bleed. It was just ooze around the pancreatic bed, and the whole clot was within the lesser sac. I think pancreatitis played an important part in terms of hemodynamic instability post-transplant and also sepsis. And then obviously cerebral edema was there before the operation. He had severe cerebral edema, which because of other factors, intra and post-op, didn't recover, and that's how we lost him.
Tough case. Rakhi, you have any comments?
This Acinetobacter, was it known before transplant or was it identified after the patient was?
Before transplant also, ma'am.
It was known before transplant.
Yes, ma'am. Respiratory, PCR, multiplex PCR. ma'am.
But was the ID involved in the management of Acinetobacter?
Sensitive antibiotics were given, ma'am. Already pre-transplant also.
No, because you were showing Zevicefta.
Yes, ma'am.
Zevicefta doesn't work. The only bacteria with Zevicefta will not
No,
cover.
we started with Zevicefta. In preoperative period, we also patient was also receiving Zevicefta.
No, so Zevicefta does not cover Acinetobacter.
Yes, ma'am. But sensitive to colistin also and intermittent, we have both.
So the thing
Pylorus and
is, we
Zevicefta.
saw the Acinetobacter is very high and now the sensitivity for colistin. So that's a worry. And this patient also we lost because of Acinetobacter.
I think one of the major issues in this patient was pre-transplant. Also, you had to do a CT angio to see whether there is a vascularity, and it did show vascularity. It was a tough call for taking such a patient. But my feeling is the patient on day one itself with the pancreatitis, which is so rare in hepatitis B flare, probably was the tilting point. Anyway.
CT was severe cerebral edema,
Yeah.
pre-opsy.
Yeah, he had.
Severe cerebral edema. Although vascularity was there, that's why we thought that whatever chance he has, because there was a donor available and young guy, and the only chance he had was with liver transplant. So that is why we went ahead. He was already on colistin before the operation. Colistin, because he was already on CRRT, and colistin was started before the operation as well.
Okay.
So
We have another presentation by, okay. We have limited time, but sorry, we should have kept time for you.
Good morning, everyone. Today I'm going to present morbidity and mortality myth from the Department of Intervention Radiology. This is the data regarding the various vascular procedures which were done in the preceding 3 months. We performed about 10 TAs around 28, microwave around 40, tips in around 30 patients, Parto in about 9 patients, and various angioplasty and stenting in 36 patients, and DSA embolization for bleeder pseudoaneurysm in about 16 patients, Permacat TJLB in about 60 patients, and PICC line in 26. Coming to non-vascular procedures, we performed PTPD in more than 100 patients, drainages and aspirations in more than 1,000 patients, FNAC in 30, biopsy in 130, and arterial and venous access lines in about 370, and ultrasound screenings in more than 2,500 patients. Unfortunately, we had 2 patients who passed away due to procedure-related complications in the last 3 months. The first patient I'm going to be describing in detail in the coming slides. Second patient was a 62-year-old male. There was a space-occupying lesion within the liver for which percutaneous liver biopsy was done. And post-biopsy as a routine screening we did, and after 2 hours, following which there was noted some perihepatic hematoma as well as some pelvic hematoma. Following which CT angiography was done to rule out any active contrast extravasation. There was no evidence of active contrast extravasation. However, patient was planned to taken up for embolization. However, patient and the bystanders didn't consent, and also as the patient was hemodynamically stable and conscious and oriented. The next day, patient started having hemoglobin drop with being hypotensive and requiring inotropes. The following day, we did transarterial embolization of hepatic artery using gel foam, and volume resuscitation was done. However, after 2 days, patient expired due to refractory hypovolemic shock.
So just hold on. So this patient, can you tell us the detail how this patient was monitored after he was shifted from IR to the respective department overnight?
We performed biopsy at around 1 o'clock. And after that, we usually, every patient, we will do a routine screening before we discharge or before we send them back to ward within 2 to 3 hours. And in that, we noted there was some perihepatic hematoma as well as some pelvic hematoma. So we wanted to do CT angiography to rule out active contrast extravasation.
So when he was shifted back to IR, I've been told his lactate was 16.
Sorry, sir.
When he was shifted back to IR, he was on double inotrope,
Yeah,
and his
next
lactate
day.
was 16.
Yeah, next day he was on.
This is in hospital patient, right?
Yes,
This
sir.
is a patient in hospital who underwent a procedure.
within 4 to 5 hours, we had planned to take on the patient for embolization. Patient was on table as well, and patient, however, didn't consent, and patient bystanders as well didn't consent for
So
the
that
procedure.
was next morning, right?
No, that was
next morning.
same day.
That was next morning, right? You said next morning patient was shifted, right?
Patient was actually
patient was taken that day itself, just after we had that CT angio and it was negative. Still, we asked the patient that because CT angio is negative, but there is a sizable hematoma. So we asked the patient was taken on the vascular lab. He was on the table. On the table, patient denied, I don't want to get anything. And their attendants also denied, we don't want anything. And because everything was stable, it was finally said, ki, okay, fine, whenever there is any further clinical deterioration, we'll take. So he was taken immediately after 3 hours of biopsy. So if you don't know, sir, please listen to us and please believe us. We believed everything when you said. We believed everything.
So because we showed the details, we showed events in a proper way. The events are not.
So maybe he's not as good in English as you.
वो बात अलग है पर
सर हिंदी में बता देते हैं उसको लिया था
हिंदी में बताना
उसने मना कर दिया हम लोग सर शायद इतने अच्छे सक्षम नहीं है आपको अंग्रेजी में समझाने में इसलिए बताते हैं
ऐसे कमेंट करोगे तो कोई डिस्कशन का फायदा नहीं होगा
नहीं आप बीच में रोक रहे हैं you are interrupting in between let him complete.
Next time you present this case with details, there is a concern raised how the patient was monitored. So maybe next time you can present how this patient was monitored and it will help in standardizing.
Event can happen to anyone.
I would like
to us also problems happen, complications happen.
Also to present along with it.
How it was detected, how
it was detected in routine ultrasound,
how it went on.
Otherwise, we have lot many things to say about liver transplant patients also. So please don't start all these things.
No,
everything is here. All slides come. Each and every morbidity, mortality comes here.
Even we are trying to give you the complete picture, and we are neither admitting patient nor we are taking a decision for biopsy. We are presenting just because we have done a biopsy.